Okay, for the next talk, please welcome Dr. Christopher Parr. Dr. Parr's lecture is also sponsored by our partner, Ogden Regional Medical Center. So please clap and stand if you're from Ogden Regional. Thank you. All right, so Dr. Parr.
All right. Okay, yeah, so with that brief introduction, my name is Chris Parr. I've been an IR doctor practicing here in Ogden for about the last 20-something years. And so this is my presentation here about chronic venous disease. It's my disclosures. So I get paid from Cook to do artery stuff, and Becton Dickinson, who manufactures some of the stuff we use for this, did help out with the slideshow. So I went to Cochrane database to see what Cochrane has to say about that. And of course, the studies are not up to Cochrane standards. They say they range between poor and intermediate quality. So I said, well, that opens the door for me to give you my biases and opinions and experiences. So you get my veins my way. Now, I have a 16-year-old daughter who, you know how 16-year-old daughters can be, but thinks she's a music maven. So I was gonna, as a doctor, still, if we use, I don't know if we use the word pimp anymore, but when we quiz our trainees, I was quizzing her, and I said, I'm gonna give this talk, and I'm gonna talk about doing it my way. Like, do you know who sings that song? Now, she's only 16. And so, but my 9-year-old son was there, and he's like, I know who sings that. And I was like, oh, wow, that's surprising. Who? And he said, the Mouse. And I'm like, the Mouse? I don't know the Mouse. But the Mouse is the character from Sing, the cartoon movie. So anyway, these are the versions of my way, which you guys will get to pick at the end. If this presentation, my way, is the smooth, polished chairman of the board, Frank Sinatra. This guy, that's the Vicious of the Sex Pistols, who was at the lead of the punk rock movement, more attitude than maybe skill, and then the Mouse. So, with that introduction, here we go. So, the signs and symptoms of chronic venous disease. There are broad manifestations of chronic venous disease. Why some people get varicose veins, or other people get ulcers without varicose veins, or other people get restless legs. We don't know the answer to that. It's probably multifactorial, has to do with a lot of underlying things. But because of that, there's a lot of different presentations clinically speaking, which probably the most common is varicose veins, and then edema. And in my experience, the least common is venous claudication. That's pretty rare. I've had only a few patients that have had that over the years, and usually those are younger, fit people. But the other things are, subjective symptoms like heaviness or fatigue because the blood pool and the leg builds up, and they literally are heavier because they have all this extra blood pool in them. The dermatology people could probably go more eloquently onto the venous stasis, dermatitis, dermatosclerosis, and skin staining. The most severe form is venous ulcers, and phlebolymphedema, where you have more permanent, like rubbery edema, because the chronic venous hypertension drives fatigue in the lymph system, and ultimately you end up with lymphedema. So what are the risk factors? Of course, one of the major drivers is gravity, because of this venous pooling in the leg. So the longer we're here, the more subjected we are to gravity. So age, genes, like most disease states, play a role. A history of DVT, or superficial venous thrombosis, which is related to the destruction of the one-way valves in our venous system. The venous system doesn't have an active pump. We don't have little peripheral hearts pushing the blood back to our center. It requires a passive pump, so we need the one-way valve. So when we breathe in and drop our thoracic pressure, that same pressure drop is seen by the venous system in our legs, and it pulls our blood back into our thorax, And when we breathe out, then the valves are to hold it in place. The same thing with the muscle pump component of veins. When we're doing things that are beneficial, it propels the blood in the right direction, and when we're doing things that aren't. But if the valves are destroyed, then or are dysfunctional, then they can't do their job, and blood just goes where gravity directs it. The other risk factors are increased weight, which probably has to do with increased abdominal girth and more difficulty with getting the blood out because of increased pressure. And then being a woman, both due to pregnancies, probably due to cable compression and back pressure, but also just the sex hormones seem to drive varicose vein formation. So this is a slide that shows the prevalence of chronic diseases. So, almost every specialty is going to see people with this because of its high prevalence. Now, the difference between all those other things that they've chosen to compare to with Alzheimer's or strokes, cancers, PAD, diabetes, all of those have a high mortality associated with them. So if you get them, you don't linger for long. But with venous disease, you get it, and then you have it. Doesn't cause your demise. There's not a high associated mortality. So there's a big pool of people that builds up because it doesn't have the same mortality issues as the other diseases there. But as you can see, this is a big amount of people. And so it's estimated to be 175 million people, so that's a lot. But not all of those people obviously are going to need treatment, but out of those, it's estimated that 100 million might have severe enough disease that it may warrant some kind of treatment. So this is a slide that shows the economic impact of the chronic venous disease. And of course, all these societies and everyone who does studies has sort of a motive to make it appear dramatic. So there's a 300% difference between the highest and lowest, but needless to say that it is a vexing and costly, especially when it gets to ulcers, because the ulcers are difficult to heal and require prolonged treatment periods often and use a lot of medical resources. So as I was saying, the venous ulcers are the most impacting in terms of the medical costs. Out of all the lower extremity ulcerations, venous ulcerations are much more common than arterial lower extremity ulcerations, although there is a fair amount of overlap between the two. So sometimes it's not all purely straightforward. And there's the other thing is there's a high recurrence rate of once you've had a venous ulcer, your chances of having another is fairly high. And so the other slide showed kind of the prevalence of venous disease overall. This shows the incidence of venous ulcers, again, compared to these other sort of chronic, more intense healthcare diagnoses. And so it ranks up there with cancer and coronary disease and so forth. All right, so here's just another slide that shows sort of the underlying pathophysiology of what is the underlying driver of all chronic venous disease. No matter what the manifestation is, the underlying defect is these diseased valves, which may be diseased because the vein dilates, may be diseased because it's had clot in it, it may be diseased because you got bad genes. But whatever the case, when they cease to work as one-way valves, then you get what we call venous reflux, which just means that gravity is able to pull blood where it wants to go, and it's not a one-way system anymore. So a brief review of the anatomy. So we have the deep and the superficial system. The deep system is responsible to carry 90% of the blood out of your leg. So these superficial veins, the great saphenous vein and the small saphenous vein, which are the blue veins on here, are are usually the offenders. They have the most profound impact on reflux because the deep veins are surrounded by muscle, and after they get so distended, your muscle will smush them down. And even though it's not maybe as effective with the one-way valves, it's like squeezing a toothpaste tube in the middle, it's going to propel things in every direction. But the great saphenous vein and small saphenous vein are often offenders, and since they're only contributing in a perfectly balanced leg about 10% of the outflow, they really can be viewed as spare parts, which is why we use them for bypasses, etc. But also, if they're causing a lot of problems, they can be eliminated. All right, so the classification scheme that we use is the CEAP classification, which C stands for clinical. The EA and P basically get ignored. It's for etiology, anatomy, and pathophysiology, which are maybe useful for academic studies. But for clinical practice, really, everything hinges upon the clinical classification, including the insurance coverages. So in order for us to do anything, we have to classify these patients. So C1, like insurance won't pay for, that's considered to be cosmetic, which is reticular and spider veins. The difference between those and varicose veins is the size. So the deemed cutoff is 3 millimeters. So if all your veins are 3 millimeters or less, that's a cosmetic problem. If they're greater than that, then you have varicose veins, and then that gets you in C2 category, and depending on your clinical symptoms, you may be eligible for an interventional treatment. C3 is edema. In this case, it's quite striking. So this person probably has had chronic disease long enough that they've developed phlebolymphodema, so all of that's not just edema that you could shrink away if you compress the leg and so forth. It's going to probably have some static component of lymphedema there. Then continuing on to higher classifications, you get pigment changes, eczema, collagen buildup, or lipodermatosclerosis, where the skin becomes thick. If you palpate it, it feels woody. I liken that to the body's trying to build itself a compression sock because it can't swell anymore. It gets rigid. Then here we have C5 is for a healed ulcer. I don't agree that ulcer's healed. It looks like it has a little hole in it to me, but it's nearly there. And then C6 is an active ulcer. So basically from C2 to C6, you can treat if you have the appropriate symptoms and so forth. But before we treat, what would we do? We should treat them conservatively. So the bedrock treatment for venous insufficiency is elevation, compression, and exercise. So this is the most motivated patient I've had as far as elevation goes. You've got to get your ankles above your heart. Like a footstool that is not elevation. So, I tell them you've got to drain the blood out of your legs. You got to get your ankle higher than your heart. So yeah, that's the most motivated patient. Compression socks, people have ideas that they're, ugly or uncomfortable, etc. I mean, there is a lot of options available, and almost everyone can find something that works. That 90+% of the patients are going to get by just fine with just calf-high compression. Usually we use 20 to 30 millimeters of mercury. That's where we start out. That's what, in order to get insurance coverage, if you want to go on to treatments, that's what you need to document. And then exercise. These are the least motivated folks because that's not going to do anything for your venous disease. You got to actually get off your chair and do some good aerobic exercise for the legs. All right, so what's the rationale for our procedural treatment? So when the conservative measures aren't sufficient to control or they interfere too much with someone's lifestyle or whatnot, trying to elevate all the time and so forth. So then we offer treatments. Treatments they're not really a cure. Very rarely will people be cured, but they are very successful at helping to manage the disease and decrease the amount of other things you need to do to keep it under control. And so, yeah, I clipped this out of the paper. I liken the veins system to a basketball team. So even if every vein in your leg doesn't work very well, the way you can make the whole system work better is you cut the guys who are the worst. And then even if the system doesn't work very well, just like a basketball team, like if you get rid of the bums, your overall performance will improve. So that's the strategy of what we do. So how do we figure out who the bums are? So as mentioned, usually the offenders is the great saphenous vein that was figured out hundreds, if not thousands of years ago. But so in order to get any treatment, you have to do imaging to confirm that you've got the right diagnosis and that it's sufficient to warrant treatment. So here's a picture of a duplex ultrasound. The part above the line is the blood flowing in the normal direction, and in this case, the patient valsalved, and then you can see that drives the blood backwards below the baseline. So when you valsalve it, it's pushing blood backwards, venous blood that should be going up to your heart. It's pushing it backwards down your leg, and usually that needs to go on for 500 milliseconds, which is half a second. That's the definition. In this case, they don't have it labeled, but you can measure it on the ultrasound machine. It gives you very accurate measurements of how long that's below the baseline, and then the person breathes in, and you can see that spike where it does pull blood up when they take their breath in, and it starts going in the right direction. So we do that in various places all over the leg, and we generate this map that shows us where the good veins are, where the bad veins are, where we might treat, where the worst reflux is. And then we make a decision about if we want to proceed with treatment or not. So what are our treatment options? So I thought what we would do is review the history of varicose veins, because that's going to cover pretty much all the treatment options. So the first mention of varicose veins, which somewhat surprising, is this old papyrus. It's 3,000 years old. I didn't know papyrus could last that long. I would have thought it needed to be stone tablet or something, which I wonder if it was describing a thrombosed superficial vein, because it says it's hard. But it was described as this tortuous solid, as if it was blown up by air. So that's the earliest mention of varicose veins. Then from the base of the Acropolis, there's this giant leg. I don't know if that's supposed to be a Greek god or whatever, but if you look very carefully, sort of down the medial great saphenous sort of distribution, you can see a varicose vein there. And then Hippocrates, of course, we all know Hippocrates. Most of us took some sort of oath along the lines of his reasoning, but he figured out that the only way the body could ever get rid of varicose veins is if they thrombosed. And so the treatment then was, how can we induce thrombosis in the veins? So they would heat up a metal implement and jam it in your vein, just right through the skin, or get a bunch of thorns and try and stick your vein a bunch of times and see if they could induce thrombosis. So various other breakthroughs happened. A lot of Romans and Greeks were doing it. This fellow in the 600, who's also a Greek, figured out that the great saphenous vein was really the main driver of pressure into these veins. And then for about almost 1,000 years, nothing happened. And then Leonardo da Vinci started making anatomic drawings and so forth. An Irish surgeon invented the hypodermic needle, and then people started figuring out how to strip veins without just cutting you open or injuring your skin a lot in the course of trying to get veins out by pulling them out through holes on either ends. Dr. Seldinger, who invented the tools that were necessary for my specialty to exist, interventional radiology, he's the guy who figured out if you put a needle in a vein and put a wire through the needle, you could slide all sorts of things over the wires. And before that, you had to do a surgical cut down, and they would open it up and put whatever you wanted in the vessel. He was the guy who figured out how to get around that. May and Thurner, Charles' daughter, in 1964, that was the beginning of IR. That was the first IR case. He used a speedometer cable from a Volkswagen Bug, a piano wire, and a ballpoint pen spring, and managed to manipulate that into a lady's leg that had a stenosis, that had an ulcer, and it worked. And so that was the beginning of percutaneous kind of treatments in interventional radiology. And then ultrasound developments, and then really the biggest, so we were still stripping veins, which often was an inpatient procedure, took several days because you'd get fairly wide resections to get the veins out. Then in 1999, then that was the first radiofrequency where we used the Seldinger technique to get into a vein, put a little tube in there, it has a cauterizing tip on it, and was able to seal the vein up using that. Now it took about, still another decade or so before that was accepted and insurance would pay for it and so forth. And then, of course, there's all competing techniques with lasers because everything's cooler with a laser. In 2008, the Clary vein, which is not used much, but it uses chemical plus a wire that's like an egg beater. We put that in the vein and put the chemical in and let that kind of help aid the closure of the vein by beating it. And then in 2015, which is the latest kind of advance, the system, the VenaSeal system came out, which uses super glue, basically proprietary cyanoacrylate polymer to glue your saphenous vein shut. The benefit of that is you don't have to anesthetize the patient when you inject it because it doesn't really hurt. The downside is that some people have a really severe reaction to the agent, and if your immune system goes crazy on it, the only way to turn it off is to cut it out, which sort of destroys that purpose. Anyway, so basically the summary of the treatment methods are to treat varicose veins or chronic venous hypertension, all those manifestations, is surgery, chemical sclerosis, radiofrequency ablation, which is probably the gold standard. That's about 80% of the market uses that. It's the most controlled. It has a low profile side effects, and it has a lower rate of neovascularization or recurrence of the problem. Chemical sclerosis or glue. All right, so that is the conclusion of mine. Did you guys download that app that you can vote of which one I am? Oh, here it is. It's other. Okay. I'm guessing you were thinking of this guy who also did My Way. Anyway, thank you very much. And does anyone have any questions? Does anyone have any varicose veins? I have a clinic, you can come and see me.